to another guest lecture by Dr. C on tandem surgery, cervical and lumbar spine surgery. That's an interesting topic by Dr. C from Philippines.
Good day to everyone. It's my pleasure to talk to you about tandem spinal stenosis and the surgical options of this condition. I'm Dr. Ibet from Philippines, and it's my honor to be invited to this meeting. Next, please. Next slide. So again, it's not rare that when we see a patient with cervical spinal stenosis, there is a concomitant lumbar spinal stenosis, as seen in the MRI of this patient. Most commonly, tandem spinal stenosis includes cervical and concomitant lumbar spinal stenosis. And in some, there is also thoracic spinal stenosis. Next, please. Tandem spinal stenosis usually arises from spine degeneration in a patient with coexisting congenital stenosis. The usual presentation is a triad of intermittent neurogenic claudication, progressive gait disturbance, and mixed myelopathy and polyradiculopathy in both upper and lower extremities. Next, please. The prevalence of tandem spinal stenosis is 0.9 to 16.7%, with other studies quoting as high as 60%. On the average, it's 10% prevalence rate as is the usual. Mostly, this entity is seen in older age and male patients. Next, please. With regards to radiological findings, as by the Wakayama spine study in Japan, the prevalence of cervical spinal stenosis is 25%, lumbar is 30%, and tandem spinal stenosis is 11%. And among those with tandem spinal stenosis, symptomatic cervical and lumbar spinal stenosis were present in 10 and 19% respectively. Next, please. Next, please. The presence of symptomatic stenosis. I think you can go back one slide, please. So the presence of symptomatic stenosis at a region predisposes a
Hello.
patient to develop progressive
Mhm.
stenosis in another region of the spine. This is especially true in conditions
आप
of
15-20 मिनट
OPLL
बाद
and
करूँगी.
ossification of ligamentum flavum. What defines spinal stenosis is the Torg-Pavlov ratio of 0.8 or less. This is the ratio of the AP diameter of the spinal canal and the AP diameter of the corresponding vertebra. Of particular note is the presence of asymptomatic tandem spinal stenosis, which, when unrecognized, may lead to post-operative complications of weakness, like when doing posterior lumbar decompression surgery with a patient on prone position, the neck perch. With asymptomatic cervical spinal stenosis, the patient may wake up after surgery with symptoms from compromise of the cervical cord. And this should always be considered by the spine surgeon treating spinal stenosis. Next, please. So even though thoracic stenosis is not common, there is a 15% incidence of neurologic deterioration of patients undergoing lumbar surgery. Again, the presence of OPLL, OLF in East ASEAN patients are risk factors, and the deterioration of post-surgical patients is ascribed to tethering and cord hypoperfusion. Next, please. With that, I have tried to search available literature on tandem spinal stenosis, option of treatment to include simultaneous surgery and stage surgery. So a valid question is simultaneous surgery for tandem spinal stenosis a viable option of treatment in this condition? So there are roughly just around 14 articles. 3 articles were double entries, and 2 articles were case reports. So now let's run through the present evidence. Next, please. So with regards to cadaveric and morphological studies, it was mentioned that around 2% of morphological population had tandem spinal stenosis. The concomitant cervical and lumbar stenosis is found in 5.4%. So why is this so? Why is this less than the prevalence reported? Was probably because soft tissues, discs, and ligaments in clinical practice are not seen in morphological cadaveric studies. For radiographic tandem spinal stenosis, the risk factors are more than 70 years of age, male, and multi-level symptomatic lumbar stenosis. Next. So the diagnosis is usually a combination of clinical assessment using the modified JOA, NURIC, ODI, or Oswestry Low Back Pain Disability Questionnaire, electroneurophysiological exam, and MR and CT modalities. Next. Again, because of the positive linear relationship between the AP diameters of the cervical and lumbar canals, an imaging or MRI of the whole spine may be warranted to diagnose tandem spinal stenosis. With regards to treatment, there is no consensus. One stage, two-stage surgeries, or surgery of the symptomatic region only, simultaneous surgery, cervical or lumbar surgery first, are mentioned in the literature. Next. Yamada et al. Show that either two-stage or tandem surgery may give good results, while Idogan et al. Preferred stage surgery to decrease the risk of tandem surgery in patients with advanced age and comorbidities. Next slide, please. One option is to address the cervical region first, as recommended by Shea et al., as this resulted to improvement of patients with lowering the need of second-stage surgery. A period of 3 months post-op for reassessment is usually recommended to ascertain the need for a second surgery to the lumbar spine. Next, please. Luo et al. Mentioned that surgical correction of cervical stenosis first significantly lowers the need for a second-stage surgery for the non-operated lumbar stenosis, and that if lumbar spinal stenosis surgery is done first, there may be an exacerbation of the cervical stenosis symptoms, necessitating a second-stage surgery. Next. So this shows the algorithm proposed by Baker in the treatment of tandem spinal stenosis. On the left, if the predominant presentation is cervical spondylotic myelopathy, cervical decompression is first done. On the right, simultaneous surgeries may be considered for patients less than 60 years, none or less comorbidities, contiguous lesions like cervicothoracic or thoracolumbar junction disease, and if minimally invasive techniques may be done to reduce surgical insult. Next, please. So this is a similar algorithm suggested by Cao et al. Next. Lee et al. Specifically mentioned that for thoracic compression with lumbar spinal stenosis, simultaneous surgery may be considered. If stage surgery is considered, again, just like favoring cervical, thoracic decompression should be the default surgery to avoid neurological worsening from cord compression. Next slide, please. Simultaneous surgeries are considered by other authors as by Tsutsimomoto, Kishnan, Kikwe, and Eskander. Next. So why simultaneous surgery is advocated? The literature mentioned that this potentially reduces the financial burden, risk of repeated anesthesia, and rehab time. There was note of no significant difference in outcome, whether OR time was less than or more than 150 minutes, and blood loss was less than or more than 300 cc. What is important is adequate decompression, surgical techniques, and proper fixation if needed. Next. Again, for simultaneous surgeries, either one or two teams may be employed, as the latter may further decrease OR time. Of note is the conscious effort for proper positioning of the patient, whether simultaneous or stage surgery, so that positioning would not aggravate the stenosis of the patient. Next, please. So I'll just be showing my personal experience of doing tandem spinal stenosis across 7 years. So this includes around 45 patients. This is roughly around one-fourth of the individual cervical or lumbar spinal stenosis patients. Male to female ratio is 1.8 is to 1. The mean age is 60.9 with range of 37 to 85 years old. Consistent with other studies, MRI and CT were done as necessary. My practice still to do targeted MRI and not whole spine MRI based on the clinical presentation of patient and considering the cost in the Philippines. Considered stenosis for cervical is less than 10 millimeters and for lumbar is less than 11 millimeters. Next, please. The position of the patient was prone with cervical decompression done posteriorly. One team did simultaneous surgeries, beginning with the proximal segment, then subsequently doing the distal segments. Half underwent purely decompression procedures without instrumentation, and also almost half had instrumentation and fusion, either cervical or lumbar. The operative times, hospital stay, blood loss were not significantly different from those undergoing single surgeries. The outcomes are also good as all improved and had follow-up periods from 3 to 36 months. Next, please. So in summary, simultaneous surgeries may be offered to patients with symptomatic tandem spinal stenosis who have acceptable comorbidities. This indeed is more economical and potentially decreases the risk of repeated anesthesia and rehab time. As long as adequate decompression, proper surgical techniques, and fixation if needed are employed, the outcomes are good. Next. So for patients with tandem spinal stenosis, but with asymptomatic segments, only the symptomatic segment should be dealt with first. Proper positioning and surgical techniques should be observed to avoid worsening of the asymptomatic segments. And adequate follow-up of the patient should be done to monitor, especially the asymptomatic segments. Thank you for listening.
Thank you, Professor C. Are there any questions? Uh, it's a very interesting topic. I have presented this in two of our meetings. My question to you is, like you are divided into cervical, thoracic, and lumbar. And my point is, thoracic being a very long segment, and physiologically there are two different parts, upper thoracic and lower thoracic, D10, 11, 12. So is it appropriate to divide thoracic into two parts also? Like the T1 to T6, then T6 downwards, something like that. And if we are operating on two levels, let's say T1 to T4 and D10, 11, 12. So should that also be called as tandem surgeries?
Yes, I've done a few of those cases, but it's not actually for stenosis. It's for patients with infection, with POTS. No? So ideally, you have to divide the upper thoracic and lower thoracic, but regardless of dividing, you can do them. No, if you have both symptomatic segments and significant stenosis, you can do them in tandem.
Thank you very much, ma'am. Thank you so much.
So my bias only to this is I would tend to, let's say for the cervical region, no? So I would tend to decompress via posterior approach rather than anterior approach so as not to reposition the patient.
Yeah. Thank you so much. Thank you.
Thank you.
So